Morning, good afternoon. I would like to welcome everyone to the Secure webinar number 20. And in this session, we'll be discussing the public-private partnerships in healthcare. We'll be exploring challenges and opportunities in Asia and the Pacific. I would like to first welcome Dr. Alexo Esperato, a Senior Health Specialist at the Human and Social Development Office at the ADB, for welcome and opening remarks.
Hey, thank you, Bas, and greetings, everyone, and welcome to the 20th Secure webinar on public-private partnerships in healthcare. This webinar is jointly organized by the Secure Regional Technical Assistance, as well as the Technical Assistance and other regional technical assistance on strengthening primary care management for non-communicable diseases. ADB, as you know, has been sharing innovation on health security topics in Southeast Asian countries through this webinar series as well. As you're aware, health systems face numerous challenges. These include limited infrastructure, human resources, and therefore access to care in rural and underserved areas, marginal populations, and so on. Public-private partnerships have the potential to expand care and serve universal health coverage also for marginalized groups. ADB has been supporting public-private partnerships through its Office of Markets Development and Public-Private Partnership Services, which entails work in several fronts. Firstly, through capacity building, training, and knowledge sharing on public-private partnership-related topics. Secondly, on creating an enabling environment for policy, regulatory, and institutional frameworks for public and private collaborations, as well as transaction advisory services on financial matters, right? These include deal restructuring, risk analysis, financial modeling, and so on. And then finally, by mobilizing funding for public-private partnerships through both its sovereign, which are public-oriented, as well as non-sovereign, which are private-oriented work. In this session, we will hear from leading experts on the lessons learned, as well as the various opportunities and challenges entailed by public-private partnerships. So I encourage everyone to participate in this dynamic event. Thank you very much.
Thank you very much, Alex. So just briefly for participants that might not be familiar with ADB. So ADB has been established since 1967 with the members of 69 countries, and more than half are actually in Asia, but also including countries outside of the region. So ADB is based in Manila, and the collaborations are with the governments, private sectors, and also with development partners, both in the public and private domains. With this role, not only on transaction advisory, but also for knowledge support. We just wanted to highlight some of the key documents, especially on Strategy 2030, and in particular in not only to eliminate extreme poverty, but also envision a prosperous, inclusive, and resilient, sustainable Asia. And with this, we are working with the government on the loans, technical assistance, and grants, and then various equity investments. So in this session, next please, we'll be discussing the technical assistance and also how the ADB and ADB health sector are formed. So just generally, we are working across various key trends, and this is from the urbanization to demographic changes, also all the way to digitalization of society. The focal area has been not only from the government governance point of view, but also strengthening infrastructure and also promote innovative financings and also enhancing the workforce. We also focus in various cross-cutting priorities from gender equity to actually in the last few years and in the future into promoting climate change mitigation and also adaptation. And health system preparedness for COVID-19. All of these are really to strengthen the health systems and also toward the universal health coverage. Next, please. And this really brings us into this seminar today, where under the Sustainable Development Working Groups, we have put together the key area in which we can support under regional technical assistance as part of knowledge dissemination. So in this webinar, we'll be looking at the role of the PPP, and also we will divide into two main panels. The first one is on experience sharing, followed by lesson learned from PPP projects, Q&A, and then synthesis. I'll first introduce the first part of the speakers in the experience sharing. We have Mr. Amit Goyal from partner in Ernst & Young India. He has been leading the team working with us in technical assistance at least for the last part of the year. He has more than 20 years experience in health, and he has been instrumental in working with various strategic planning, advisory. He also has direct experience with over 30 healthcare PPP transactions. We also have Mr. Alok Kumar, who is also a principal secretary with the government of Uttar Pradesh. And we are really privileged to have him in this session. He's a senior Indian administrative service with over 30 years of experience, and he plays a key role in shaping India's healthcare landscape. Last but not least in the session, we have a perspective from private sector, Mr. Rohit Singh. He's the CEO of international business of Nephroplus with over 2 decades of experience in PPP. He played a very key significant role in launching dialysis clinic with over 165 machines in Tashkent in Uzbekistan, and we'll be here about his experience today. Without further ado, I would like to pass on to Mr. Amit to start the session. Thank you.
Dr. Vatantra, and thank you so much for having us in this webinar. So before we start on our experience learned through various PPP projects in health sector, we'll briefly introduce the PPP concept. Basically, PPP concept is a long-term contract between government and private sector to develop any asset and services on behalf of government. And the core idea of PPP is to leverage the expertise, efficiency, innovation, and investment by the private sector. At the same time, government's role is to monitor the PPP contract and also to ensure that public policy goals are met. So basically, as we have seen globally and of course in Asian countries as well, we have various challenges in health sector, which includes limited infrastructure availability for the provision of healthcare services. We also have limited availability of necessary technology, equipment, and other services to provide quality healthcare services. There is also a limited availability of specialist doctor, clinical workforce, and lack of specialized trainings and exposure to clinical advancement in public health facilities. Along with that, we also see a lot of challenges in terms of limited coverage of insurance, and patients are required to pay from their own pockets. And then most of the patients are traveling to outside of their home cities to avail healthcare services. Like the limited availability of healthcare services in rural or remote areas is a biggest challenge we have in developing and low income countries. Along with that, there is insufficient funding to provision healthcare services, also a problem statement. And in service provisioning, we have a problem of limited, primary and preventive healthcare services, significant urban and rural disparities in accessing the quality healthcare services. Also, lack of specialized services and care continuity are some of the key challenges in the health sector. So, to overcome these challenges, there is a huge potential to leverage private sector expertise in overcoming of setting up of infrastructure, which could be setting up of hospital, medical college, nursing colleges, diagnostic centers, and to improve healthcare services uh, and reduce the gap in providing healthcare services in remote regions. We can use private sector expertise to implement telemedicine, teleradiology, and tele-ICU kind of facilities. And also, we can leverage private sector capacity in enhancing the emergency preparedness. Apart from that, we can also leverage private sector capacity in terms of managing and operating the infrastructure developed by the public sector, and also ensure sustainable financing, often with performance-based payment models, and also manage hospital and inventory management. And then there are certain services which can be outsourced to private sector, which include diagnostic services, ambulance services, dialysis, cath lab, mobile medical clinic, Linux services. These are some of the examples, and not limited to these services only. There are other various services which are non-clinical in nature, where we can, leverage private sector efficiency. So now we'll present the case study which is related to the development of 500-bedded multi-speciality hospital in one of the most populous state in India, which is Bihar. So this project was developed in the city of Patna. The problem statement in the state of Bihar had includes healthcare infrastructure deficiency, high patient load in the public health facility, also limited access to medical services, shortage of healthcare workforce, patients traveling to other cities like Delhi, Vellore to avail healthcare services. We just had 0.06 hospital beds per thousand population, which is lowest in India in the state of Bihar. And we just had less than one doctor per thousand population in the state. And the district hospitals were operating at 200 of their capacity, of their normal capacity, to provide healthcare services to the citizens of Bihar. So with this, government conceptualized this project, and the government's role was to provide 7 acre of land parcel to the private sector, including some of the utilities, which include water, power, and sewerage facilities, and also to monitor the KPIs. The private sector was responsible to set up the 500-bedded hospital. The private sector was also supposed to, finance, develop, equip, operate, and maintain the super specialty hospital for the concession period of 30 plus 30 years, and also responsible for recruiting the manpower, the hospital management information system, so that real-time monitoring can be done, and obtain quality certification like NABH and NABL for the healthcare services. So in this particular project, there were two type of patient. One, select patients who could not, avail services at by who could not pay for the healthcare services, and government of Bihar was reimbursing to the private sector for the healthcare services availed by the select patients. All There were around 50% of the bed capacity was reserved for the select patients, and those beds were like general beds created by the private sector. And other than that, there were market patients for which the prices was also capped at CGHS rate, which is the central government health scheme, which has a subsidized predefined rate for more than 3,000 healthcare packages. And the developer was flexible to, charge for the rental for semi-private, private, and super specialty, super deluxe beds in the facility. The authority provided land on lease basis to the concessionaire, and was also responsible for the reimbursement for the select patients to the concessionaire. The bid parameter in this particular project was annual payment by the concessionaire to the government, and there was 1% revenue share fixed for the concessionaire to the authority. The impact of this project was it was one of the first successful greenfield hospital project in Bihar, providing holistic healthcare services at an affordable price, and also having skilled medical professionals, advanced technologies, and comprehensive range of specialties. This also increased the access to the ICUs, advanced diagnostic facility, and super specialty care for more than 29 super specialty services. The private sector increased the bed capacity in the state by adding 500 beds, and also provided access to tertiary care access, and also installed diagnostic services. This reduced the patient load in other public health facilities, and all provided healthcare access in the unserved location of the Bihar. It also helped government to reduce patients to reduce their travel to other cities to avail healthcare treatment. This some of the lessons which we learned from this project was the contract should be designed in a manner where we have minimum government interventions. Also, there should be a robust monitoring mechanism and evaluation system. The simplifying and expediting regulatory approvals, which help the private sector to get all approvals in short time, and the private sector was able to start the operations in timely manner. And also, we learned that balancing public interest with project effectiveness required careful stakeholder engagement, and there has to be transparent policy with clear risk sharing mechanism and foster trust and accountability between partners. The other project which we conceptualized with the government of Jharkhand to implement statewide network of diagnostics and radiology pathology services uh, through hub spoken spike model. So in this particular, the problem in the state of Jharkhand was they didn't have the diagnostic facilities in public health hospitals, and also the residents of Jharkhand, either they were not having any diagnostic done or they were relying on the expensive private sector facility to get their diagnosis done, which led to high out of pocket expenditure. And to address this gap, Government of Jharkhand initiated this hub spoke and spike diagnostic model on PPP framework in 24 districts of Bihar, there are 24 district hospital and 3 medical colleges. So there was in the state there was a shortage of 95% medical specialist doctors, 84% shortage of radiologists in public health facility, and there were no laboratory technician in 33 public health facilities. So the objective of this project to provide high quality radiology and pathology services to estimated population of 32 million, and which also the other objective was to enhance primary and preventive care by advanced testing facility across all locations in the state of Jharkhand. So before we move on to the PPP structure, the project was segregated in two clusters. We had 12 districts in one cluster and remaining 12 districts in another cluster. So we had the 3 hubs in each of the cluster, the hub for radiology had CT scan, MRI, and PET scan facility. And in the remaining district hospital, ultrasound and X-ray services were made available by the private sector. For pathology, again, in the hub level, all laboratory tests were available, and in the remaining district hospital, limited test facility was provisioned by the private sector to provide lab tests which were required at district level. And there were some community health center which were made as the collection center, where the private sector will collect the sample of the patients in community health centers. So in this, the role of private partner was to install, equip staff and operate the diagnostic center, and was responsible for the capital investment, and also implement robust management information system for critical information sharing with government of Jharkhand, maintain and upgrade the machines during the concession period, and also to ensure quality and manage the consumable inventory required to conduct all kind of tests which were provisioned in the concession agreement. The role of government in this particular project was to provide brownfield or greenfield space wherever the space was not available. The private sector was supposed to set up the building for providing diagnostic services. The government was also supposed to provide the water, power supply, and sewerage network outside the campus network, and monitor the key performance indicators as defined in the concession agreement, and also to facilitate patient flow from the government hospital to diagnostic center, which were established on PPP model. There were two kind of patients, one the market patients and the other one select patients. All patients were charged at CGHS rate. The For the patients below poverty line, government of Jharkhand was reimbursing to the private sector, and the bidding parameter for this particular project was annual premium to the government by concessionaire. This annual premium again was deposited in the escrow account to cross subsidize or to reimburse the private sector for BPL patients availing diagnostics facility in this particular center. So some of the key learning from this particular project was that this statewide network in Jharkhand has significantly enhanced the access to affordable and quality diagnostic services. This initiative also improved early disease detection, reduced financial burden on patients, like the patients were not required to travel more than 15 to 20 kilometers from their home location. And this also helped government establish diagnostic center across hospitals and medical colleges, and implementation and the hub spoke model, integration of advanced technology. And this also helped government in improving the accessibility at affordable price, like free and subsidized diagnostic was available for any kind of patient, free for the select patient and subsidized for the market patient. Availability of services closer to the rural and unserved population. This has significantly reduced the out-of-pocket expenditure for the patients. This also helped government of Jharkhand in doing the disease surveillance, because the service provider was supposed to share the kind of disease these patients are having through the diagnostic reports and reporting on monthly basis. This also improved internal public health capacity by having these facility within the public health hospitals and medical colleges in the state. The Some of the lessons which we learned from this particular project includes integrated hub and spoke model improves efficiency but needs robust infrastructure. Workforce shortage persists, necessitating parallel investment in both in-house capacity and external capacity to develop and ensure long-term sustainability for both government and the private sector. And strong governance and monitoring mechanism ensured service quality and compliances. So with this, now I would request Alok sir to share his experience of implementing one of the biggest medical education program on PPP. Alok sir.
Thank you, Amit. Can we share the hello, good morning, everybody. Good afternoon. So this project was about increasing the supply of healthcare professionals, state of the largest province. The- So the problem statement essentially was that we had a very low doctor to population. And the reason for this was largely because while hospital beds were available, very few beds were used for teaching and training healthcare professionals. For instance, every district which typically has a population of 3 to 4 million would have a large 100, 300 bedded. None of it was used for training medical. Similarly, there will be very large private sector who will be treating patients, but they will not be using. So the idea was, how can we use every single hospital to be converted into a training center for healthcare? And what we targeted was one district, one medical college. One district, as I said earlier, is typically the population. Next slide. So, and what we did was that we realized that we had to go both for state investments and also for leveraging private investments. So, out of the 75 districts which comprise the state of, we had only 39 which had one medical college or more. There were 39 districts which had no medical college. And this idea was how to saturate each and every district so that at least that will have at least one medical college. And this was done. So on 23 districts, we had upgraded the district hospital into a medical college. So state operated district hospital was upgraded and necessary infrastructure that they become medical. After those 23, there were 16 which were still left, and these were the most difficult districts, partly because of low paying capacity patients, and also because of the fact that these are geographically remote. Therefore, it was difficult to attract talent to these districts. And that is where we conceived of this method of trying and ensuring that these 16 difficult districts, unserved districts, could be served by medical, at least by one medical college. Next slide, please. So we adopted a kind of cascade policy, and I would like to give the rationale of this policy. So typically speaking, 70% of the healthcare occurs in the private hospital, and only 30% happens in the government hospitals. But government hospitals practically provide services or very low cost services, and therefore they act as a check for poor patients, so particularly poor patients who might have otherwise access to a district, a private hospital, and their services, but won't be able to afford them. They can approach the district hospital, and therefore the district hospital is almost the hospital of the last resort. And that is why politically there was a little bit of a reluctance to hand over these district hospitals to private operators, partly because of the incentives which work in the private sector. So we had a cascade model. First model was where private person could bring in his hospital as well as his land. In that case, we provided a back-end subsidy of the cost of training students at the rate of 28.8 thousand USD per student per year. The second option was looking at those who had private hospitals but did not have land to expand that private hospitals. So the land was provided by the government, hospital was provided by the private. And in that case, the scale of assistance was 11.5 thousand US dollar per student. And then we had this model 2 where the government of India announced a viability gap funding scheme, whereby the government of India partially funded setting up of social infrastructure. And that in that was that you hand over the district hospital, also hand over the land to expand and create the necessary infrastructure to run a medical. And the government provides maximum of 40% of capex support and 25% of the OPEX support for the first 5 years. Next. So this was the model that we were talking about. So in the first two models that I had discussed earlier, they were not really in that sense, but it was private investment to subserve a larger public cause, and to incentivize those investments, we were giving some kind of a back-end subsidy. This model was largely a PPP model where the government provides the district hospital as well as the land to expand as per. So there is a regulator for who's taking the medical. They have some land requirements as to whatever was available and additional whatever was required. And also the government provided a viability gap funding, which was the bid parameter to which we selected the private. The period was 33 years, extendable by another 30. And the bid parameter was essentially the lowest capex plus opex grant. net present value of their capex and OpEx. To ensure that the poor people don't suffer, we had a two-part payment system for the beds which were already existing in the district hospital. They were declared as free beds, for which the private sector would not be able to charge the patient. And for those beds which were to be added by the private sector, they could charge specified rates which were specified in the constitution. So this is how this project was structured. I think we inform next slide that we have been able to 4 medical colleges have become operational under the scheme. 6 we have done the bidding part and is now almost very close to the award process. The remaining 6 are under the process. And overall, we have added about 6,700 beds with a capacity, IPD capacity of 0.5 million, annual capacity of 0.5 million patients. And the private sector has invested about private sector and about $160 million is the estimated government side. And by this, we will be able to add 1,600 doctors per year. And apart from the added clinical workforce. So I think largely the idea was how do we leverage our existing hospitals to enhance the training of the medical professionals. And in this, we leverage both the private sector hospitals and the government sector hospitals in order to add. And this was done in a period of 2 to 3 years. So it's something that is achievable in a very, very short period of time. So from the start, I think we started in 2020. And as has been pointed out, 4 have already become are nearing awards, so they will become operational for the next academic year. So that is what I have. Thank you so much.
Thank you so much, Alok sir, for your presentation. Now I request Rohit to discuss his experience of dialysis project in Uzbekistan.
Thank you, Amit. Thank you for giving us the opportunity to NephroPlus. We'll be discussing about our PPP project. It was the first international PPP project that NephroPlus had undertaken in Uzbekistan. Government had come with an international RFP where various global players participated, and then we secured the project in 2020. The whole objective of the project was to enhance dialysis services and quality. The state healthcare is a state subject. Government is the provider and the payer in Uzbekistan. So the whole objective of the project was to enhance dialysis services, reduce cost per dialysis treatment to bring in efficiency in the system, develop more infrastructure, so solving for access in dialysis, and obviously introducing advanced technologies, and at the same time improving the skill level of the people who are working in the medical space. So the project was envisaged in 4 centers, primarily in 3 regions: Republic of Karachi, Pakistan, Kyrgyzstan region, and Tashkent region. These are 3 regions where mapping was done, where the patient load was identified and gaps were analyzed, and then the RFP was released, where we were supposed to set up a greenfield and a brownfield blend of both. So NephroPlus had set up a greenfield center in Tashkent, which is one of the world's largest dialysis clinic with 170 bed capacity. And we had set up a 3 clinics in the balanced 2 regions. So the model was to build, operate, and transfer, build, own, operate, transfer, the boot model. Tenure of the project was 10 years from operationalizing the last center. And the total investment that went in was close to 8.4 million USDs in executing and starting these 4 dialysis centers in Tashkent. So there was a clearly defined roles of the government or the public partner, and there was very clearly defined deliverables for the private partner. On the public side, they were first before the planning stage. Obviously, they mapped the country and they identified the need and the gaps. During the project, which is as we speak going on, they are supposed to manage the wait list and provide the private player or NephroPlus with the patient flow as per the agreed terms or as per the agreed assurance on each location. Government also worked on setting up the national dialysis standards, that how the national level dialysis will be delivered across the country. Third, they came up with a minimum guarantee based on the patient load, that in each location, what would be the guarantee that would be given to NephroPlus. And that was a very significant point in giving a very competitive cost. And then pay for the guaranteed treatments there. Also, government plays a very active role in monitoring the outcomes and the service quality. So there is a frequent auditing mechanism that has been put in place, and the clearly deliverables identified for the private player or NephroPlus to deliver. NephroPlus role there is to identify location in the two areas, and one area we were provided, so there where we built. So it was to either renovate or build. This was a case of blend of both. Complete setting up from designing to setting up to installation of the equipment and operationalizing the whole clinic. Recruit staff and train them. As you can understand, there were certain gaps in the skill level. So we had to recruit, train, send a lot of workforce from India to monitor the clinical quality and the skill level of people. Provide dialysis at the patients that are referred by the Ministry of Health there. And then we were also responsible for educating the patients on transplantation, that how this while dialysis is required when the patient is on the end stage renal disease. But at the same time, we have taken up several campaigns, and we continue to do so, on educating them on the benefits of the transplantation and what all options are available for them. And besides that, NephroPlus submits monthly and quarterly reports as agreed with the government, depending on our quality outcomes and our SLAs defined. So there are periodic reporting on the outcomes as well as operation SLAs that is submitted. What was very impressive was the impact of the project. I think till now we have done close to 280,000 treatments have been provided till now. Significant decrease in mortality. In the first 2 years, when we analyzed the data, there was a 40% decrease in mortality by standardizing and protocol-driven dialysis. 1,100 patients were surveyed to check the satisfaction score, and 4.7 was the rating in this 1,000+ patients that we surveyed. NephroPlus Academy has now trained over 300 nurses, so we are upgrading and upskilling the nursing there, which also would be helpful in cross-border employment as well. We are looking at employing few of these nurses in our newer projects that will be coming up in Saudi Arabia. At the same time, government saved a significant amount, where initial pricing or the cost to government was close to $85 a treatment. NephroPlus offered them this quality service at $50. So there was a significant saving of over $8.4 million during the course of the project. And at the same time, I think which is very special is, given the protocols, given the regular monitoring and training, up-training, the hepatitis C patient count reduced by 15%. And this cross-learning in the other parts of the dialysis clinics in this country has also helped. So largely the impact has been very significant in saving mortality, cross-infection, and providing dialysis at scale. So that's a interesting case study from our side. Thank you, Amit.
Thank you so much, Rohit. Now I request Jay to take over.
Yes, thank you very much, Amit. So for the next session, it will be lessons learned from the PPP objectives projects. But before going to the speaker introduction, I would like to remind the audience that there is a Q&A box on the bottom of the Zoom. I'm already seeing some questions. Thank you very much. You can, of course, identify yourself, but can remain anonymous if you wish. Please feel free to ask questions. And for the speakers as well, you will have time for a real-time Q&A, but feel free to type in the answer you think if the question is for you. So for the two speakers we have for the sessions are Dr. Dawal Jam and Mr. Paul Darita. Dr. Dawal is a Principal Markets Development Advisory Specialist at ADB, and he leads the ADB's Health Sector PPP Transaction Advisory Services. He has over 20 years of experience, including 15 years in advising on PPP transactions, and specializes in social infrastructure. And before joining ADB, he worked in the PPP Transaction Advisory team at the International Finance Corporation for about 12 years, and he's also a doctor by training. And if I may also introduce Mr. Paul Darita, he is a founder and principal of PDR Infra Advisory. So Paul is an experienced PPP practitioner and senior executive who has worked with many public and private sector organizations in delivering innovative and complex healthcare PPP projects across the world over 20 plus years. Currently, he is focused on the two areas of work that he has a real passion for, which is health PPPs and emerging markets. And since then, he has provided strategic and project advice around the world for a number of clients, including IFC, World Bank, Clinton Health Access Initiative, ADB, AFDB, and EBRD. And previously, he also led PPP projects in IFC and PwC. So not other further ado, I will hand over to Dawal. Dawal, please.
Thank you, Jay. Actually, the way Paul and me would be working on this session is that Paul will start with a few examples. We're talking about PPPs, which includes a few global examples of and different types of PPPs that have been implemented across the globe. And following that, I would add a few lessons, a couple of very high level and themes and messages which come out from all the PPPs combined together. And then we will take any question and answers in the Q&A round. So without further ado, I'll just share the presentation and give it over to Paul.
Thank you, Dawal, and good morning, good afternoon, everybody. Hope you can all hear me okay. So very quickly, we'll run through a few slides that sort of set out some of the global experiences of health PPPs, but also the evolution of PPPs over the last 30 years or so. And maybe we can start with a very quick definition. Dawal, next slide, please. Okay, so and actually, it's always nice to see definitions that are relatively similar, if not exactly the same. So the previous session, you'll note, had also a definition of PPPs, and this is not very much different at all. So effectively, it's about mobilizing private skills, private finance in delivering public services or assets, typically through a long-term performance-based contract. Next slide, please, Dawal. And so whilst we've seen health PPPs around the world now for about 30 years or so, it's quite interesting to note that if you consider why governments typically are doing PPPs, the objectives, or at least the reasons, are pretty similar, right? So three main themes emerge when you look at the global experience. One is, and again, some of this is very similar to what's been covered in the first session, but the first area is that governments are struggling to improve services. They are also increasingly struggling with mobilizing capital, and as costs increase, efficiency becomes ever more important. So these typically are the things that we see as the primary reasons why governments are looking at PPPs as one of the tools that they might use to improve healthcare. And of course, on the PPP side, the objectives are really about identifying and allocating long-term risks, quite often about whole life approach to asset delivery. Again, governments have struggled over time not just to build assets, but actually once they build them, to maintain those assets in an efficient and cost-effective way. PPP is also very good at ensuring predictable budget commitments, so the governments can properly budget and know that they have a fixed cost for a period of time. And of course, we want to bring in more capacity into the public sector from the private sector. We want to bring in industry best practice, and of course, the financing is also important. Next slide, please, Double. So just look briefly at the evolution of the PPP model in healthcare. And we start on the left-hand side of this slide with the most common still today used model, the infrastructure model, which started back in the UK in the mid-1990s. In the UK, it's known as the Private Finance Initiative, or PFI, but it's effectively a model based on delivering new hospital infrastructure and other types of healthcare infrastructure for the public sector to then operate. I would estimate that around the world, even today, over 90% of all projects that we see in healthcare PPPs are infrastructure PPPs. As governments got more comfortable with those types of projects, they then started to think about, actually, could we use the private sector to deliver some more complex things for us? So could we start addressing specific service needs? And again, we've already heard some of those examples around the imaging hub and spoke models in India, and there are examples of those types of projects around the world, from diagnostic facilities in Brazil to radiotherapy facilities in various parts of the world. One of the key differences between service PPPs and infrastructure PPPs is that they tend to have much shorter life contracts. So typically an infrastructure PPP may have anything from 15 to some cases over 40 years contract. Service PPPs tend to be 10 to 15 years max. And then moving along the evolution of the models, we then see what is now the most complex of PPP models, commonly known as the integrated model. And here we see the private sector being brought in to deliver not just construction or an assets, but also delivering all of the clinical services on behalf of government. There are, again, various examples of these around the world. They are primarily aimed at delivering hospital services, but not always. We've seen primary care also being delivered through these types of contracts. And the payment structures for these types of PPPs are very, very different from country to country, project to project. And we'll touch on a couple of examples of that later on. Next slide, please, Double. So here we'll obviously we'll talk about some of the lessons learned at the end of the presentation, but let's maybe start that theme right now in terms of understanding how to make PPP successful. So what is it that we see around the world that either means a project is likely to succeed, or indeed, if some of these things are not there, they are likely to fail. Again, none of this is earth-shattering for anybody. I'm sure these are the types of things that you would expect to see, and I'll just maybe focus on one or two of them. Complexity is always one of the key issues here. So, and we talked about already the types of PPPs and integrated PPPs being the most complex. It's always important to try and make these things the least complex you can for a variety of reasons, both in terms of the public sector's capacity to both implement, but also then to manage and oversee, but also particularly in emerging markets, ensuring that there is a vibrant private sector that can deliver the types of projects that we want to do in those countries. So the complexity is something that we always have to keep an eye on. Fiscal space is clearly very important. We know there are a number of projects around the world that have run into problems primarily because of their long-term cost. And again, we'll touch on one or two examples of that as we go through the presentation. So it's important that governments understand not just the cost at day one of a project, but the likely impact over the life of that project on the public sector's purse. And so a detailed analysis of the costs are very, very important. And then one last point just to focus on here, it's important that PPPs do not become isolated from the rest of the health system, and therefore they have to form a very close part of the wider health strategy. And again, I'll show you an example briefly where perhaps on a particular project that didn't quite work, which led to some of the issues that it had. We can move on to the next slide, please, Double. So just some very broad reflections here before we look at a couple of examples of projects. And again, some of these things seem obvious, but it's amazing how often people lose sight of some of this. So ultimately, a PPP is merely a financing and a procurement tool. It will not turn a bad project into a good one, although it can turn a good one into a bad one if you're not careful. So therefore, what that means is that projects have to be assessed on their merits, separate from how it's procured. So detailed analysis, call it a business case, call it a feasibility study, whatever you want to call it, but a detailed technical, financial feasibility assessment of the project to make sure that the project has its own merits on it, separate from how you then procure it, is very, very important. The PPP model, therefore, should be chosen on the basis of a clear policy from the government, or indeed some strategic objectives as to what we're trying to fix. So what I mean by that is, if we go back to the very early PPPs in the UK back in the mid-1990s, what led the government to undertake those projects was that they struggled to deliver public infrastructure on time and on budget. So quite often, large hospital projects would be delayed by 5, 6, 7 years and would cost 3 or 4 times as much as budgeted. So the PFI structure, the infrastructure PPP model, was derived specifically to address that concern. So it's important that you understand when you're developing these models what you're trying to do with the model. As we've already said, these are complex projects, so the public sector requires strong skills and experience that is not always readily available. And what I mean by that is not just advisory support, although clearly that's important, but also internal support and expertise. We've talked about cost analysis and the importance of that. And again, looking at affordability is always critical. And of course, we need both political support and stakeholder support for these things to be done successfully. Moving on, please, Double. Okay, so we'll look very quickly now at a couple of cases that illustrate some of the different models. So here we have 2 infrastructure projects that both of which I've worked on over the years. On the left-hand side, we have a 600-bedded hospital in Stockholm in Sweden to replace Sweden's preeminent research and teaching hospital. 25-year contract to design, build, finance, and maintain both the infrastructure and the medical equipment, with a total investment cost of approximately 2 billion euros. This project was financed through a hybrid structure of concessional financing from the European Investment Bank, commercial bank loans, and the capital contribution from the Stockholm municipality. The hospital was delivered on time and on budget, and the public sector continues to provide all of the clinical services. Similar example in the UK, and in fact, actually, interestingly enough, these 2 projects were done by the same sponsors. So these were both done by a combination of Skanska Construction, the large Swedish construction company, and Innisfree Investment, which is a UK-based infrastructure investment fund. So Barts NHS Trust is one of the largest hospitals in London, has operated hospitals in the capital since about the 13th century, and had a desperate need to replace much of its infrastructure. So again, similar contract, but very long term in this case, 42-year contract. The reason for that length of contract is that at that point in time, it was attractive to issue capital markets bonds for the financing of the project, and the maturity on the bonds allowed the project to benefit from effectively lower costs for the government over time. Again, same principle, public sector continues to provide all the clinical services. Next slide, please, Double. We've skipped one. Great, thank you. So very quickly, two examples of the more complex ends of the PPP spectrum, which are the integrated PPPs, one in a mature economy in Spain, one in a very less developed economy, but also more importantly, a much less developed healthcare system in Lesotho. Very different structures. The one in Lesotho structured on the basis of an annual payment for a volume of services. In Spain, the project structured very much in a way that fits with the existing healthcare system in Spain, which was the capitation-based system. But otherwise, they're very similar. So public sector is the regulating entity. The private sector delivers both infrastructure and clinical services. One has run into difficulties. Lesotho is probably well known now for running into a number of issues, primarily of financial nature. And those issues are partly because the government did not integrate the project properly into the wider health system, but also it didn't regulate the way patients access the new hospital, right? So there was no formal referral process in place. So people were coming from around the country to the shiny new hospital because that's where they thought they could get the best treatment. So again, both integration into the wider health system and understanding the financial impact of the project and managing that appropriately are critical components to any PPP. On the flip side of that, slightly more positive story, in fact, a much more positive story in Spain, where effectively the government let this long-term contract. It found that the quality was at least as good, if not better, than the existing public hospitals, but actually the costs were significantly lower. So a very, very different outcome to the one in Lesotho. But even Alzira had its initial teething problems. So originally, the hospital had only control of the tertiary services, and the public sector doctors in primary care, particularly, were just sending everybody to the hospital. So the contract was restructured to allow for the private operator to also manage the primary care within its catchment area, so that it could better decide how to best treat those patients. I'll stop there in terms of the presentation. I'll now hand over to Dawal to cover off his final comments.
Sure. Thanks, Paul. I mean, you laid out all the issues and all the lessons learned from different projects, and especially from international experience also. And I would really like to highlight and press upon the issue of how health PPP projects where clinical services are involved, the integrated kind of models, are the most complex kind of PPPs amongst all sectors. And they really require a lot of capacity on the government side to be able to implement those projects. And one theme that also regularly comes out of the project is that PPPs do tend to increase the quality of health services which come out in terms of health outcomes. But definitely there are fiscal impacts, and I will be touching upon these issues in a minute. Paul was just talking about three structures. One is, the integrated one, and one is, where clinical services are involved. One in the middle is only for services, and the first one, which is the most common PPP model, is the infrastructure only model, where the hospital infrastructure, including equipment, is brought in by private sector and built and maintained. The kind of model, the question of which model is more applicable to a particular country or a particular project, there's a simple litmus test. There's a simple question, answer, or decision tree which you can use. And what is the need or the objective of a project? Of why do you want to implement this project? And if there is, the need is infrastructure. Now, most of these infrastructure projects, which are successful PPP projects, have been implemented in countries where the problem or the issue that was going to be resolved was infrastructure and financing. because these countries, mostly in developed countries, they had requisite staff and management capability to run the hospital. So what they needed from private sector was the infrastructure only. Whereas in many countries which are still emerging markets, developing countries, the solution which they need to look at is depending on the health system. There are countries where there is enough manpower and management capabilities, and they follow the same um pattern or the models of successful PFI or infrastructure kind of projects. But most of the countries have the requirement of improvement of quality or provision of clinical services. So the type of project that you need to choose depends on what problem you're trying to solve as a government entity, and there's a little flowchart out here. You can say that if the motivation or the objective of the project is to develop infrastructure, and if there is enough staff available, then of course go to the infrastructure only PPP project. But enough staff or management capability is not there, then you look at a full service integrated PPP, wherein the private sector builds the hospital and provides all clinical services too. Whereas if the primary motivation for implementing the PPP project is provision of clinical services, then you ask the other question: is the necessary infrastructure available? And if the answer is that no, it is not available, and so you have to then go to an integrated model where there is, infrastructure and clinical services both provided by private sector. Or of course, you can first create this infrastructure, develop it on your own, and then ask private sector to just provide O&M. But I've not shown that model here on the screen because that has its own complications. But yes, if infrastructure is available and the facility is ready to be operated, then you procure private sector for provision of clinical services, which is an operations and maintenance or operations and management PPP contract. So this is a kind of the landscape of which type of model one government would look to implement. Each of these models have their pros and cons, and there are many lessons learned from all of them. But at the basic question, the first question is, will the PPP project, when you build it, when you implement it, will it be able to provide intended services? If you build a hospital but you don't have clinical services provision, the ability to provide clinical services, then the hospital will be a white elephant. On the other hand, if you do an O&M contract with a private entity and they do not have the requisite building infrastructure and equipment or consumables, then they would not be able to operate it. So you have to think long term in a hospital PPP project, and you have to think of, will the project ultimately implement, once it's implemented, will it be able to provide the intended services for what it was built for or implemented for? So that's the first thing of how to look at it. And then one point which I wanted to talk about, and this is a very broad term and it affects all PPPs, irrespective of the type of PPP that you talk about, is what are the primary drivers or the primary objectives for implementing a PPP project. And it kind of mimics what is required in a health system. And the four pillars of a good health system, which get trickled down to, say, a hospital PPP, is the private partner is supposed to, the project is supposed to have efficiency of operations, which, it has impact on the quality, affordability, and costs. It should have equity, that the same kind of service should be provided to every patient that comes here. So there is no preferential treatment or differentiation between treatment depending on who the patient is. Of course, quality improvement is the cornerstone of PPPs. At least it is one pillar of a health system, but quality is usually the biggest pillar for which PPPs come in. And the last one is affordability. And having all these four outcomes is a tricky situation, because when you look at cost of providing clinical services or health services, then from a PPP perspective, the private sector will bring in efficiency, which is again well documented, and the way the documents are designed, they do bring in efficiency. So there's no doubt about it. And efficiency will reduce the cost of providing clinical services to some extent. But when you increase the quality and equity, which also is a known fact, one theme which came up with all the PPP projects, even the ones which are criticized heavily, one thing is that the quality of services do increase. So that's one given for a PPP. The criticism come for different reasons, mostly about fiscal impact and others, which I'm trying to touch now. But quality does increase. Equity depends on how the contract is designed. And overall, between this balance, it may turn up that the cost of providing services may increase, especially because it's a positive feedback cycle, and the quality of health provision increases, so people tend to go to a place where the quality is higher. For example, we have a classical example of Lesotho Hospital in Africa. There was only one tertiary care hospital in the capital city, which was a PPP, and the services improved tremendously. It became an island of excellence, and so people started bypassing all the other public hospitals in the vicinity of where they were staying, and they were traveling hundreds of miles to get treatment at this particular hospital. And so this hospital became overburdened. And since the private sector was providing clinical services, they would, invoice the government for those services that they're providing. And so it started affecting the budgets. It ended up with a huge fiscal implication on the government. If you talk about on a quality basis or a per patient cost basis, it might show positive results out there, especially on the quality side. But when it comes to the overall fiscal impact, it was higher because this hospital ended up treating 46% of the overall intake of or admissions of a country. So this is definitely which affects the overall cost of providing health services. And so between this balance between increasing costs due to quality equity and decreasing costs of efficiency, let's see what the impact of this is, the fiscal impact. And what happens is that someone has to pay for that increased cost or the higher quality coming out there, and then the government may choose to pay that, which becomes a huge fiscal liability on them. And we have seen this sort of criticism in many projects, especially when one project has been delivered in one particular political regime, and a few years later, when people change in the system, even at working level, then we see a criticism coming up from projects that, oh, the project is too expensive. Because now the good quality and other thing, efficiency and all, which are there in the project, becomes a given, and people don't have the sight of how the hospital operations were before this private sector came in to provide services. So someone has to pay for these improved services, and it can be either the government, or it could be out-of-pocket payments from the patient's license, or a mixture of both. And that's where the affordability of a PPP gets affected. If government payments are increased, then there's a higher fiscal liability, although the affordability increases for the end user. But if there is a fiscal limitation of providing that budget, then the out-of-pocket payments will go high, and then it affects affordability of attaining these services at the hospital. And so this this balance is very difficult to maintain on a very long-term basis, and this particular aspect starts affecting health PPPs in the long run. And I'm talking from the point of view of where clinical services and integrated kind of PPPs do come in. Thanks. That's it from my side. I think back to you, Jay.
Oh, yes, thank you very much, Dao, and thank you very much for the speakers for the very informative presentations. So we'll go over to the Q&A session now. Thank you very much for the active participation. We have 11 questions in line, and I've seen that already a lot of questions were answered by Mr. Rohit and Amit. So first, we will start with the questions which has not been answered yet at the typing answer. So first of all, there was a question from, apologies on my pronunciation, from Funkam Ratanavong. So the question was, how is different between PPP and hospital autonomy, and which model it would be better from your experience? And the related question was that, can it be combined or not, the PPP and the hospital autonomy? And also, because it's the question from the same person, he was also asking, for PPP, do you have any projectional plan, or what will happen after contract or project ending? So would there be any volunteers who would like to answer this question?
Yeah, I can take that, Jay.
Thank you, Dawal. Yep.
So first of all, Mr. Ratan Wong, I just would like to mention that actually it is not an exclusion, or it's not a difference between PPP and hospital autonomy. PPP is a modality, whereas hospital autonomy is the decision-making process of how to run operations. In fact, in most PPPs where private sector does come in to provide clinical services, they need full autonomy on operations to be able to provide the quality outcomes which are required from them from the PPP contract. So if a PPP contract says that you need to have, you need to provide, say, dialysis services, then those dialysis services, there are certain quality parameters. And if you do not meet those quality parameters, you do not get paid. And the only way I believe a private entity can ensure this is if they have full autonomy of how they are providing those services. If there is any interference, then they would not be able to meet those KPIs. So autonomy and PPPs, in fact, clinical services PPPs go hand in hand. It's not either one. They usually go together. But if it is about creating autonomy, as in a decentralization of hospitals, I think this question may be related to that aspect. PPPs or without PPPs, it doesn't matter. And if the government believes that the decentralization can be done on their own, there is no need of private sector, then very well, they should go ahead and do it. But if there is a requirement, like I showed in the first flow chart, that if there is a requirement either on the infrastructure or on the clinical services, then you achieve that through private sector and retain the autonomy and pass on that autonomy to private sector in that way. So that's how I would put it. Of course, if I may take half a minute more, in an infrastructure only PPP model, the autonomy is divided, because the autonomy of how to manage the facility will be and maintain the facility will be on the private partner, because that is their responsibility. And the autonomy of clinical services, diagnosis, and what treatment to provide will be with the government side, because they will be in charge of that particular aspect. And of course, both these entities have to talk to each other about their various operations and decide an interface of how they will be working together. So again, the moot point is that autonomy and PPP are not separate entities. They, in fact, are very much things which go together.
Oh, yes, thank you very much, Dawal, for the answer. Just a follow-up questions they had. It's what will happen after the contract or project ending for PPPs?
Can I maybe chip in on that if I may?
Paul, thank you.
So typically the contract will foresee what happens at the end of the contract, right? It'll put in place a number of conditions. So for instance, if it's an infrastructure PPP, it will look at the conditions in which the building and the asset should be handed back to the public sector. And there will be a number of tests that you do. So in the UK, for instance, right now, the first PPP contract in healthcare coming to an end in the next 3 to 4 years. There is already a huge amount of work going on to assess those hospitals, to assess the condition they're in, and to make sure that any issues are identified and dealt with before the contract terminates. If it's a clinical contract, then obviously you need to understand and figure out what happens to all the staff. Do they revert to the public sector? Do they effectively just melt away to another project, or what happens to them? And the contract will need to set that out very clearly, and typically do that. And some contracts also have an obligation to, or at least a right to renew, right? So you can renew for a further 10, 15 years, whatever it is that you want to do. There are a number of different ways in which you deal with the end of the contract, but typically they are all spelt out in the contract.
Thank you very much, Paul. Yes, I remember Dawal mentioning it's all about the contract and conditions. So several hundred pages of having this PPP project. Going to the next question is from Dipijoti Banerjee. So I'll read out the question. My question is, what are the primary demands or support that a private entity looks from the government when starting a greenfield multi-specialty hospital project, which involves huge capital investment? Considering the huge CAPEX and OPEX costs for providing quality healthcare, what could be the pricing strategy for private operators, and what role does universal insurance coverage play in this context? I think it's a very comprehensive question. Would anyone like to take this on?
Yeah, so maybe I can start and Dhaval can add to it. So there are various factors which a private entity would look from the government side. One, there should not be any fixed financial burden on the concessionaire towards payment to the government, like premium, upfront premium, annual premium, something like that. Second, there should be a provision for viability gap funding in case these facilities are being set up in remote locations, which should include CAPEX support and OPEX support. And third, there should be a limited intervention in the operations of the private sector once the contract is signed and the project is implemented. And there should not be any free patient in the facility. Either the patients are paying for those services, or the government or insurance company should pay for it. So for the private sector, there should not be any free patient. And there has to be a strong governance mechanism. Once the contract signed, there should be a responsible government official who should ensure that the project gets implemented on time. So basically, there are certain condition presents which are supposed to be done by the government, like providing access to the site, providing support in approvals and clearances. So those things should be done in timely manner. And reimbursement for the government referred patient should be on time. There should not be any delay in the payment to the concessionaire. And there has to be flexibility in the contract. The government should not get into the input side of the contract, like how concessionaire is developing the hospital, how they are procuring the equipment. The government should only look into the outcome and should ensure like the KPIs are complied and obligations of the concessionaires are met. Those things, in my view, are the expectations of the private sector. Maybe Dhaval or Alok sir can add to it.
Sure. I'll first request Alok sir if he wants to add anything. Otherwise, then I have a few points to make.
I think for pricing, really, there is a typical hospital to patient scenario. Hospital has an undue power, very little bargaining power. That means whenever the government gets it, it is best that you collective bargaining on behalf of the patient, and the patient also might be lower cost than what the normal. Otherwise, there is a private sector alternative. However, it is slightly finely balanced because you have to see that project is viable for the private part. Because if it is not viable, then people will not be able to attract this. I think this idea of pricing is a so for instance in the PPPs that we had done, there were two streams of revenue. One was the revenue from the students, the fees paid by the students to get the medical. And the second was the stream was the of revenue from the patients. We try to do a balancing act and we allow a little bit more freedom to them in terms of the student fees while regulating the or capping the fees that will be charged from the patients. So that is how the kind of difficult and complex decisions, and there is no one answer. It will depend on the context in which you are structuring that particular.
Sure. Rohit, yes, please go ahead.
Can I just come in? I understand it's for the hospital, but being the delivery space, I think on the larger view, when we have some visibility on the volume or the patient count, that also significantly helps in the pricing strategy of the private player. Uh, and then the second layer, what we saw, like we do a lot of PPPs, we've done with Bihar government, Karnataka government, Andhra Pradesh government. So we were able to estimate. And based on the estimate, the private player would be able to, so it's the volume, tenure, and the upfront requirement on the capex. These three inputs play a critical role in deciding the return profile. Based on that, typically a pricing is offered to the government sector. And if we have clearly defined scope, and if we have a concrete visibility on the volume or the quantum of service that is required, that also helps in the pricing strategy significantly, is what I want to add up.
Can I maybe just add a... Oh,
Yes,
sorry,
no,
Dhaval,
go ahead, Paul. No, please go ahead.
I was just going to make a quick point on, I think the question included an issue around insurance and the role for insurance, health insurance in PPPs. And actually, that is a pretty hot topic, because actually we're seeing more countries, more emerging countries in particular, looking at health insurance as a way of financing healthcare. And increasingly, we're seeing health insurance as a way of financing PPPs. I have a very specific example that I worked on, probably 15 years ago now, but I did a project in the Caribbean, small Caribbean country, that was sending most of its inpatient requirements to the US at huge cost. We developed a small PPP on 2 of the islands to provide all of that care on the islands. So it's an integrated PPP. And at the same time, we created, the first time in the country, a social insurance program that effectively then became the financing source for the PPP. So some of that is becoming more visible and more common, but again, adds a layer of complexity that people need to think carefully about.
Sure, I think all the points are covered. I'll just quickly, again, thinking from a government perspective, and advice to our colleagues who come from the government on 2 things. One is, all these parts, what have been mentioned by everyone, fine. One small additional point is, the government can help in achieving, getting the licenses for a greenfield hospital. Some countries, the regulation is such that you need almost 100 licenses to start operating a hospital. And so if any help from the government to private sector on that part would be really helpful. Now, in terms of the basic, again, it's a bit academic to say it, but many times we have seen that there is an expectation that since health is a social subject, then it is expected that private sector should come and do these projects on a philanthropic basis, and those do not go very far. It's if I may use the term, it is rather ambitious and impractical there. So the basic is that there has to be a viable business model under any PPP project. Otherwise, sustainability is a very big issue. So from the government perspective, please do keep this in mind. Otherwise, the scale of PPP projects that you want to deliver may not be that much. The second point on scale is that, especially if you want to do these integrated or clinical services kind of models, then CapEx is huge. And while these clinical service providers want to expand their services, the balance sheet does not allow to invest huge capex into multiple projects at the same time. So from a private sector entity, if they have you can pick a number, a private entity has $100 million and they want to invest in a project, and they get only one project where 100% capex is expected from them, then they invest all that 100 million into one project, which has 2 issues. One is they don't have capex to expand anywhere else. Second is they put all the risk into one project, and if that one project doesn't go well, as a business risk, it's a major effect on their business. So then private sector participation also becomes less in that case. Now, what has been seen in many countries, and India is a live example in front of us, where the VGF, which is the government contribution towards capex, it decreases the capex requirement for a project, and the higher the government contribution towards the project is, the lower is the risk seen by the private sector out there. So one entity who has 100 million total, rather than spending in one project, can invest in 5 different projects if the capex is only 20 million on them. And this kind of a scenario works well both for the governments because they want expanded services, and even for the private sector entities because it lowers the risk out there for them. And of course, again, from government perspective, if they need to put in some money for this VGF facility, then there could be government sources, or they could be sources from entities like Asian Development Bank also provides loans and all these aspects which the government can use for the long-term investments like this, because PPPs are very long-term investments. So just from a government perspective, I wanted to add these points.
Oh, thank you very much, speakers, for the very informative information. I hope we have another hour for this Q&A session, but I'm just mindful of the time. You will have to close. But if there's any questions from the audience, please email us, and we are very eager to help. For now, I would like to hand it over to Dr. Eduardo Banjon. He's the Director of Health from the Asian Development Bank. Dr. Dodo, the floor is yours.
I hope you can hear me. Sorry, Jay. Sorry. Hello from Pakistan. And thank you. And sorry, the signal's bad here. I'm actually in a car. So thanks again to the discussion on PPP. I think one of the realities we have in Asia is that the private sector is part of the health sector. I think country after country we are looking into, the private sector plays a key role. And a challenge or they are starting to grow and play a key role, whether they're providing hospital services, whether they're having private health insurance. Of course, they've always been the ones supplying the medicines and all that. So the challenge for countries has always been how to engage the private sector, how to harness them, where we go beyond just probably buying medicines from them, but actually, or having parallel systems where the private sector operates with the government, but actually have an engagement where the private sector also contributes to the objective of the government. And we know PPP is, in a sense, the way this harnessing of the private sector actually works. So it's good to hear lessons, but it's a challenge. It's always been a challenge because, as I always love to say, in health, there's universal health coverage. So concepts like user fees or allowing the private sector to get their revenues from just charging any patient is sort of inconsistent with the principle of universal health coverage, which of course the ADB prioritized. So trying to find this balance in which we harness the private sector, which countries harness the private sector, while still being consistent with UHC. Lessons from countries emerging, as countries, as all of this is going to be something we in ADB will be looking into. We recognize and we continue and we will recognize the role of the private sector, but we also have to ensure that it is done in a manner that is consistent with UHC. So thanks, Jay, and thanks to all of the speakers. Again, my apologies, I was not able to join earlier, and hope to have further discussions with everybody who is in this call later. So thanks again.
Thank you very much, Dr. Dodo, for the synthesis. So I'll lastly hand over to Dr. Vass for the closing.
Thank you very much, and thank you for all the panels for really insightful discussions, and we got really good questions, and that would be helpful for us to actually take this forward into discussing the different aspects of PPP in the health sector. That is a wrap for a secure webinar number 20, and there'll be more in the series that you can find, and also the recording and presentation will also be available after the session. Again, thank you very much, everyone, and have a good afternoon and evening. Thank you.
Thank you.
Thank you.